I have been working here in the United States. I work as a travel physical therapist, and currently I'm in the state of Illinois. So today we will be discussing about assessment and examination of peripheral nerve mobilization. So as you know, that the nervous system is basically divided into central nervous system and peripheral nervous system. So just a little brush up. The central nervous system is basically the brain and the spinal cord, and everything that exits the spinal cord is considered as peripheral nervous system. And through the dorsal and the ventral horn together, they will form a nerve, which could consist of both sensory and motor fibers. Few nerves could be purely sensory, few nerves could be purely motor. So among those nerves, we would be specifically focusing on few of important nerves and how to assess and mobilize them clinically. So we have to understand that when we are talking about central nervous system and peripheral nervous system, they are differentiated, but they exist in continuity. When I say in continuity, that any movement in the neck can actually affect something that's going on in your foot. So why does it happen? It happens because the whole nervous system is in continuity. The moment any tract that originates into one of the nuclei of the brain stem and passes through any kind of tract into the spinal cord and then exits through the peripheral nervous system. So everything is connected. So this is the basic theory that we have to understand, that everything within the nervous system is in continuity. Another important term that we have to understand is neurodynamics. Simply to put neurodynamics, it's a relationship between mechanics and the physiology of nervous system. When we say mechanics, mechanics means any kind of pressure, any kind of force, which could be a push or a pull. And the physiology is, it could be intraneural or extraneural. Intraneural means the changes that are taking place within the nerve. So that means when you apply certain force, it results in some changes that take place in and around that nerve. That relationship is called neurodynamics. Now, there are various evidences to prove that. One of them is Climber and Sink et al. You can always just access the whole article to read it, but just two important points is that any motion at the wrist can actually strain your spinal cord. So even if you're just trying to extend your wrist, it will actually strain your spinal cord. You might feel it, you might not feel it, depending on how much of intensity are you applying. Similarly, the contralateral flexion. Contralateral flexion means if I am doing the movement on my right side, then the contralateral flexion, that means flexion laterally on the opposite side. So this will be contralateral flexion for any movement that's taking place on the right side. Now, another important principle of assessment and examination is structural differentiation. Why do we have to assess peripheral nerve involvement? So if a patient comes to you and tells you that he has some kind of pain around the wrist, now that wrist pain can be possible because of the involvement of nerve, because of the involvement of the tendon, the ligament, the muscle, or maybe even some small joints that are present around the wrist. Now, you have to differentially diagnose and apply different tests just to figure out that what tissues are involved here. So it's basically to differentiate between neural and non-neural tissues. The non-neural can be any kind of tissues. And in general, you're basically differentiating between a muscle tightness and a neural tension, because muscle tightness is the most common differential diagnosis that comes along with neural tension, because they both restrict mobility and they both can be treated just differently. So what do you assess by creating neural tension? So neural tension, when increased, it's going to reproduce the clinical symptoms. Now, the clinical symptoms could be pain, paresthesia, tingling. So you're actually trying to increase those symptoms. So you have to be very careful when you do these tests. Sometimes if you apply too much of force, might actually end up giving more pain to the patient, or maybe just aggravating the overall clinical picture, and the patient is not going to come back to you. So that was about reproduction of all the neurological symptoms. Another way, another significance of neural tension is that you compare both the sides. Now, if both the sides, the response equally, that means there is less chance that one side is involved more than other. But in case of involvement, you will find a certain level of asymmetry among the symptoms. Now, the testing procedure that every nerve testing involves a certain order of movement. And the order of movement is usually documented like this. It's usually documented like this. So PF stands for plantar flexion / IN stands for inversion / SLR stands for straight leg raise. So what are the other kind of testing that you have to do? It's not just the nerve tension testing that you do. You should know how to palpate a nerve. So for that, you should have thorough knowledge of anatomy of the nerve and the places where the nerve is more superficial. You should know how to do the sensation testing. You should know the light touch, the deep touch, the two-point discrimination, and even stereognosis and proprioception. The reflex testing, the myotomal testing, and even the manual muscle testing. One very important point to understand here, and just try to focus, even if you have not listened to what I said earlier, just listen to what I'm saying now. The second point in the slide, as you can see, the test positions and maneuvers used to detect nerve tensions are same as treatment positions and maneuvers. मैं एक बार हिंदी में भी बताता हूँ कि एक नर्व टेस्टिंग के लिए आप जो पेशेंट को पोजीशन करते हो और जो मूवमेंट्स का इस्तेमाल करते हो टेस्टिंग के लिए, एग्जामिनेशन के लिए, वही सेम पोजीशन और मूवमेंट्स को आप एज अ ट्रीटमेंट भी यूज कर सकते हो. इट्स जस्ट कि वहां पे पैटर्न चेंज हो जाएगा. आप जिस तरीके से मैनिपुलेट करते हो जॉइंट्स को, वो पैटर्न यहाँ पे चेंज हो जाता है. Okay, so superficially causes की बात कर लेते हैं. So nerve compression is one of very common cause. What it does, it prevents the normal mobility of the nerve. तो कहीं पर अगर compression होगा तो एक जो nerve normally mobile होनी चाहिए, वो वहाँ पे उतनी mobile नहीं हो पाती. और आप जब उस nerve के tension को increase करने की कोशिश करते हो तो बहुत जल्दी symptoms aggravate हो जाते हैं. So this is what a nerve compression can do. Now, the restriction of movement can also be because of some inflammation. So you have to be careful कि जो restriction है वो किसी infection या malignancy की वजह से नहीं होनी चाहिए. But due to inflammation, and as a result of healing, there will be some scarring around the mechanical interface of a nerve, जिसकी वजह से उस nerve की जो movement है वो limit हो जाती है, जो हम यहाँ पे assess करने की कोशिश कर रहे हैं. Now, the contraindications, अगर कोई भी acute neurological signs है, for example, अगर किसी को बहुत ज़्यादा headache है symptoms के साथ, vomiting हो रही है, cauda equina symptoms, जैसे कि आप लोगों को पता है कि bowel या bladder की involvement हो जाती है, अगर यहाँ पे कोई acute spinal injury suspect कर रहे हो या फिर कोई malignancy या infection है. Let's just come on to the neural testing now. हम यहाँ पे बात करेंगे upper limb के अंदर 3 major nerves की, median nerve, radial nerve और ulnar nerve. इसको upper limb tension test भी कहा जाता है. अब सोचने वाली बात ये है कि इन्होंने 1, 2, 3, 4 क्यों नहीं किया, 1, 2A, 2B और 3 क्यों किया? उसका रीजन यहाँ पे ये है कि जो ULTT2 है that presents with specific patient and examiner's position. So ULTT2 के अंदर जो patient और examiner की position है वो basically same होती है, सिर्फ movement pattern change हो जाता है. तो इसीलिए movement pattern के basis पे कहा गया है median nerve bias और radial nerve bias. Lower extremity के अंदर हम sciatic nerve की बात करेंगे, which is a branch of lumbosacral plexus, जो further branch out करती है tibial nerve, peroneal nerve, and then again a branch of both together forms sural nerve. And then femoral nerve, which comes off from lumbar plexus, and then it gives further branches, which could be saphenous nerve and lateral cutaneous nerve of thigh. तो मीडियन नर्व की हम यहाँ पे बात करेंगे, जैसे कि आप इस डायग्राम में देख सकते हैं. It is originating from brachial plexus. It's passing in front of the cubital fossa. Cubital fossa में आप अगर इसको palpate करने की कोशिश करोगे तो and as you listen to me, you can actually try to palpate it on yourself. When you try to palpate the tendon of biceps, I think, which is easier to palpate. So this median nerve is right medial to that biceps tendon. So अब nerve बहुत thin diameter की होती है, तो आप ऐसे palpate नहीं कर पाओगे उसको, but कैसे पता लगता है? You should feel the sensitivity. If you're tapping exactly over that nerve, तो वहाँ पे sensitivity high होती है. That confirms that you're palpating actually over the nerve. And then, of course, it passes through between the two heads of pronator teres in your front of the forearm, and then again, it passes through आपका carpal tunnel. So carpal tunnel and pronator teres, these are two very common entrapment syndromes that you might have to treat. और यहाँ पर अगर हम evidence की बात करें तो बहुत ही मिले जुले evidence है. They don't say कि हर entrapment के cases के अंदर nerve mobilization successful है. कई बार हो भी सकता है, कई बार नहीं भी हो सकता. So you have to make sure कि आप neural mobilization के साथ जो बाकी treatment procedures हैं वो भी इस्तेमाल कर रहे हैं, so that the probability of improvement is maximum. As you can see in upper limb tension test, which is done for median nerve, patient is in supine, the examiner is facing towards the patient. यहाँ पे arm को abduct किया जाता है around 90 degree, followed by shoulder depression with the left hand of examiner. उसके बाद wrist को extend करते हुए shoulder को full lateral rotation में ले जाते हैं, and उसके बाद gradually elbow को extend करते हैं using the front of examiner's thigh. Now, to further understand, I would like you to watch this video. Upper limb tension test 2, जो again it is median nerve bias. So जैसा कि मैंने कहा था, upper limb tension test 2 के अंदर there's a specific patient and examiner's position. So यहाँ पे जो examiner है that is standing just opposite to the previous tension test. So again यहाँ पे जो shoulder का abduction है वो 90 degree ना होके it will be around 30 degrees. Elbow को extend करेंगे, laterally rotate करेंगे and wrist and finger का extension करेंगे. To further understand, let me just show you this video. So the next nerve that we are talking about is radial nerve. So radial nerve, the nerve route is from C5 to T1, and it will pass through between the medial and the lateral head of triceps into the arm. आप जब एक boxer's position acquire करते हो, you can actually palpate this within the spiral groove. And after that, you can palpate that in cubital fossa. Cubital fossa के अंदर जो radial nerve head would be the lateral most structure. So अगर आप laterally palpate करोगे, then you can find that at some point the sensitivity to pain is high. So there is a good chance that you're actually palpating the radial nerve. Now, if you go down, you can actually palpate the head of radius. That's where the nerve is superficial. You can palpate this at the junction of the upper 2/3 and the lower 1/3 of your forearm. Then you can palpate one of the branches of radial nerve into the snuff box. And let's go to the next slide. So this is how you perform the upper lip tension test 2B, which is more of radial nerve bias. So you start with depression of the shoulder and then extend the elbow. And after that, you will medially rotate the arm, and then you will flex the thumb and flex the wrist and further extend the elbow. To further understand, let's just watch this video. Now, depending on the examiner, sometimes they can change the sequence pattern. So you might see that there's a certain movement pattern given in the books, but practically when you're applying that on a patient, that movement sequence can change sometimes, depending on the sensitivity of pain for the patient. The next is the ulnar nerve. It passes through the cubital tunnel. The cubital tunnel is present in the elbow. As you can see that the nerve is passing through the elbow. It passes between the medial epicondyle and between the olecranon process. So that's where this ulnar nerve has high susceptibility of being entrapped. And then as it enters the forearm medially, it enters between the two heads of flexor carpi ulnaris, and then into the wrist, it enters through the Guyon's canal, which is a canal formed between pisiform bone and hamate, and then it supplies to the interossei and lumbaricals. Now, this is how you will perform upper limb tension test 3. Now, here, the examiner will first extend the wrist and the fingers, and the forearm will be brought to pronation, followed by the lateral rotation of the shoulder, maintaining the wrist position. Now, this is one test where you're not extending the elbow, you're actually flexing the elbow. So you perform the the elbow flexion. Make sure you are pressing the shoulder girdle down. And after that, if you want to further sensitize it, you can also add the contralateral neck flexion, as we discussed in the beginning. Any of the brachial plexus nerves, if you're testing, and if you cannot reproduce the symptoms, the last sensitization that you can do is the contralateral flexion of head, or even just simply flexion of the head, as we will further do in the slump testing. Now let's just watch it in the video. Now, these are two self-management techniques that you might even want to try by yourself. So I'm sure for those of you who are actively seeing patients, sometime to improve the shoulder medial rotation, you tell them this exercise when you try to take a towel and then dry the back. Yes, it helps shoulder too, but it's not just the shoulder. You're also mobilizing the ulnar nerve by doing that. And another is a funny one. We used to do that when we were starting in college, that you just make the sunglasses. Yeah, I think I didn't do that well, but that's how you can do it. And even you can try it all by yourself. So that's how you can stretch ulnar nerve. Uh, okay, so coming into the lower quadrant, one very important nerve, as you all know, is sciatic nerve. It originates from lumbosacral plexus. It descends down and it branches between tibial and common peroneal nerve at the superior angle of popliteal fossa. Now, there will be one communicating branch from each tibial and peroneal, which will combine together to form sural nerve. Now, sural nerve is a cutaneous nerve, so it supplies to the sensation of posterior leg. So let's just talk about slump test. So slump test is basically a test just to rule out that if there is any neurological involvement or not. It does not necessarily tell you which nerve or which nerve roots, but it will certainly tell you that if there is any neurological involvement or not. So let's just see. So that was about slump testing. Now, this is an important one, and I want everyone to focus on this. So this is basically sciatic nerve testing, which is straight leg raise. I'm sure most of you must have done this one. And the other name is Lasat test. This is basically just to rule out that if there is any lumbar radiculopathy or not. But if within the same test, you just add certain component, you can actually test the tibial nerve, you can test the common peroneal nerve, and you can even test sural nerve, just having the same basic movements. Now here, I want you to understand with help of this outline that what happens if the symptoms are appearing in the first 0 to 35 degrees of straight leg raise? It might not actually be due to the involvement of neural structures. It because the first 30 degrees just taking up the slack. तो जितना भी टिश्यू वहां पे slackened है सिर्फ वो अपने एक न्यूट्रल पोजीशन में आ जाता है जो फर्स्ट 30 डिग्री होते हैं. Now most of the neurological replication will be done between 35 and 70 degrees. So that's where if the symptoms are appearing, तब आप कह सकते हो कि हाँ यहाँ पर sciatic या इसकी किसी branch की involvement है या फिर even जो nerve roots हैं उनकी भी involvement हो सकती है. What if the symptoms are appearing beyond 70 degrees? So जो beyond 70 degrees में symptoms appear हो रहे हैं, which could be pain especially, तो उसकी वजह joint pain जो कि facet arthropathy, SI joint involvement या फिर कई बार कुछ serious condition जैसे अगर कोई neoplasm या malignancy है वो भी present हो सकती है. So this is something you all should remember. So tibial nerve, as I told you that the sciatic, it branches into tibial. Now the tibial nerve would descend straight behind the leg and it passes through the tarsal tunnel between the medial malleoli and the calcaneal tubercle. तो उसके बीच में से ये नर्व होती हुई जाती है जहां पर ये इंट्रैप भी हो सकती है और उसको हम टार्सल टनल सिंड्रोम भी बोलते हैं. Now, we all just saw how to perform a straight leg raise. So if in that straight leg raise, you just add dorsiflexion and eversion, as you can see in the picture, just remember dorsiflexion and eversion. That means you're testing for tibial nerve. Now, this is one interesting technique I want to tell all of you. So यहाँ पर आप पिक्चर में देख रहे हो कि जो सेंटर पिक्चर है उसके अंदर एक स्प्लेइंग परफॉर्म की जा रही है. स्प्लेइंग ऑफ द आपके जो इंटरटार्सल्स हैं उनकी स्प्लेइंग. अब इंटरटार्सल्स में कौन सी कंडीशन हो सकती है? देयर कुड बी अ मॉर्टन्स न्यूरोमा. सो मॉर्टन्स न्यूरोमा के अंदर अगर आप इंटरटार्सल स्प्लेइंग करते हैं when the nerve is stretched out, तो आप फर्स्ट पिक्चर में देख सकते हैं वहां पे एसएलआर परफॉर्म किया जा रहा है. तो एसएलआर पोजीशन के अंदर वहां पे जो नर्व है उसकी स्प्लेइंग की जा रही है. So this is one of the passive techniques that you can use for Morton's neuroma. Now this is again a self technique जो कि tibial nerve के लिए परफॉर्म की जा रही है. Again पहले यहाँ पे सिर्फ एक एसएलआर परफॉर्म किया गया है, उसके बाद यहाँ पे स्लम्प भी परफॉर्म किया गया है. Now, why in the third picture the girl has extended the head? Now, I will come to this later. Now, this is a part of mobilization. And also, when you extend the head, actually, the symptoms will be reduced because the symptoms will aggravate only when you flex the head. Sural nerve, as I said, that with one SLR, you can actually test 3 nerves. So you can test the tibial, the common peroneal, and the sural. So for sural nerve, what you have to do, you will perform SLR, and then you can dorsiflex and invert the foot. So अगर आप dorsiflexion or eversion कर रहे हो, that will be for tibial. Dorsiflexion and inversion is for sural. Just remember that. Just a second. This is not a great video, but just for understanding purpose. Yeah, I'll stop it there. And then we come to the common peroneal nerve. So common peroneal nerve, it comes uh, into the anterior compartment. It supplies to the lateral and anterior compartment of leg. It winds around the head of fibula, and baki aage jaake it divides into the medial and the lateral branches. So as I said, with one SLR, you can do testing for 3 different nerves. Now, common peroneal is one of that. Now here, you're not dorsiflexing, you're plantarflexing, and you're adding inversion along with SLR. That's how you test common peroneal nerve. Now, this was again something very interesting I would like to share. So यहाँ पे नर्व को स्ट्रेच पोजीशन में ले जाके जो tibiofibular mobilization है वो परफॉर्म किया जा रहा है. This also helps to release common peroneal nerve. अगर वो कहीं पर adhered है within the mechanical interfacing around that joint. So it helps to improve the mobility of common peroneal nerve. Now, this is the self-mobilization that I would like you all to do by yourself, because आप जब तक खुद पर experience नहीं करोगे, it will be hard for you to explain it to the patient and make the patient feel that. जब आपको खुद ही को नहीं पता कि वो feel कैसा होता है. Of course, it will be sensitive. That's how you will know कि आपको patient के साथ किस extent तक जाना है. Now, the femoral nerve coming from the lumbar plexus, it's going just beneath the inguinal ligament. That's one point where it's commonly entrapped, which is under the inguinal ligament. वहीं पर से जो lateral cutaneous nerve of thigh है, वो भी जाती है, and जो saphenous nerve है, वो भी वहीं से जाती है, which is mostly a cutaneous branch. So femoral nerve testing के लिए जो basic testing है, उसके अंदर patient position supine की जगह यहाँ पर prone हो जाती है. That's when the nerve is kept under the stress. Prone knee bend, as the name suggests, prone lying, and you just have to bend the knee. And there are further sensitization that you can add by adding hip extension into it. Obturator nerve, which passes through the obturator canal and further divides into anterior and posterior branches. It mostly supplies to the adductor compartment of your thigh. Let's see if we have anything to share about this. So now this is a unique position. You can be more creative. You can do it even in supine position. Uh, like you perform a Thomas test, you will just have to take the patient on the edge of the bed, which can be unsafe sometimes. So here, the examiner has kept the patient in sideline position. And यहाँ पर आप जो ऊपर इसका sequence देख रहे हो, which is sideline slash KF, which is knee flexion, and then HE, which is hip extension. So आप यहाँ पे क्या करोगे? आप sideline के अंदर hip को आप extension में ले जाके और further sensitize कैसे करते हो आप? Hip को abduction में ले जाके. So if you perform hip extension, abduction, then that means you are testing here for obturator nerve. Now, in the same position, if you do adduction instead of abduction, that means you're testing the lateral cutaneous nerve of thigh, which is also tested for meralgia peristhetica, which can be a common complication as in postpartum women, and as well as it can be, in any number of people, where you will also have some kind of numbness that's present around the lateral aspect of front of thigh. I'm gonna skip this one. Let's talk about the saphenous nerve. So the 4 steps which are mentioned here: prone lying, hip is taken into extension and abduction, and then you extend the knee and you laterally rotate the knee, followed by ankle dorsiflexion and eversion. Now, remember, if we were testing it in supine and with SLR, the dorsiflexion and eversion was meant to test the tibial nerve. Now, in prone lying, more or less similar, but here we are testing it for saphenous nerve. Not a very good video, but this is what I could find. All right, so this was mostly about examination and testing. So as we discussed in the principles in the beginning, that the positions that are used for testing are the same position and the sequence that you can use even for mobilization. So just a little bit of more trick that is added here that I'm going to talk. You can all, read the definition, but what I want to emphasize here is that neural mobilization is basically 2 types: sliders and tensioners. So if you imagine a nerve like a thread, a somewhat elastic thread. So if you're moving both ends in the same direction, that means you're sliding, which is also called flossing. If you have ever performed flossing in your teeth, or if you go to a dentist, the dentist performs certain flossing. So the flossing can be done when you move the floss in same direction, forth and back. Now, tensioners, when you move both the ends a little bit apart. Of course, you don't want to take it too much apart. And this tensioner mobilization is more sensitive. So you should make sure that you're not performing this in people who have high sin factor, who have high irritability to pain. These are all the evidence-based factors that you can always go ahead and read. I will come to the important part. As it said, greater the irritability, gentler the technique. So if the irritability is high, if the patient is in too much of pain, just be gentle to your patient. Try not to create too much of tension. Try to stay on the sliding side. Use adjunctive procedures, for example, heat or cold packs to bring down the pain, and then start with these techniques. So the sliders, which is also known as neural flossing, it is elongating the nerve bed through movement at one joint while moving another to relieve tension at the nerve. So if you're stretching one, you're actually moving the other end towards the same side to reduce that tension. But the tensioners, they're moving away from each other so that the tension is further increased. Okay, I think this might be a little bit self-explanatory. This is one example how sliders and tensioners are different. So here, you see, I told you that if we are moving the right side to increase the tension, you should go to contralateral flexion. But in this video, the lady is doing the contralateral flexion, but to the same side. So she's reducing the tension around the neck as the elbow is being extended. Now, this is, yes. So here, the two ends, they are going away from each other. So you just have to apply the same principle for all the nerve assessment and examination we just did. And this is an example of slider technique for sciatic nerve in general. Now, you can always add a tibial component or a common peroneal or a sural component within that sliders technique. So if you notice in the previous slide, so as the model was extending his knee, he was also extending his neck. Now, neck flexion is what aggravates the symptom. But that means when he was stretching the nerve in his leg, extending the neck is somehow relieving the symptoms on the other end. So that's how you perform sliders technique. Now, this one is for femoral. Okay, now this one is for, I would like you guys to think that which nerve it is. This guy's not doing anything, neither breathing, not even doing it slow, but at least just for understanding. So this was basically obturator nerve sliding technique, self-sliding technique. Okay. Now, this one is for median nerve. You can all try it by yourself. It's a simple technique. Okay, take a guess for this one. Now, what we saw earlier was a slider technique. Now, this is not a slider technique, as you can see that with elbow extension, the head is going on to the contralateral side. That means it's not a slider technique, but it's a tensioner technique for the median nerve. Can you guess which nerve is this?
So for ulnar nerve.
Very good. So this was for the ulnar nerve. And again, this was a tensioner technique because the model is taking the head onto the contralateral side as the nerve is being taken into the stretched position. Okay, that was for the radial nerve. Well, that's pretty much it. So if anyone have any questions, I'm here.
का कोई क्वेश्चन है? I think sir, no one has any question.
Chaliye, very good. I think the student
Good morning,
nowadays, they
sir.
have,
I have a question.
yes,
Sir, in brachial plexus injury, should we use ULTTs?
very good question. So now brachial plexus injury, the first thing is that how did you came to this conclusion that it's a brachial plexus injury or not? तो यहाँ पर जो भी NCV studies की जाती हैं उसके basis पर एक diagnosis आता है that there is a brachial plexus injury. If there is a complete injury, in that case there will be a complete paralysis of the arm. तो वहां पर आप इसको यूज नहीं करोगे. अगर वहां पर सिर्फ कोई ग्रेड 1 या ग्रेड 2 न्यूरोप्रैक्सिया है, सिर्फ एक नर्व कंप्रेशन है, तो वहां पर आप क्या करते हो, जो नर्व का डीजनरेशन है वो 14 डेज तक चलता है. सो यू डोंट परफॉर्म दीज टेस्ट फॉर द फर्स्ट 14 days, but after first 14 days, if you are suspecting it to be a nerve compression, then yes, you can perform the upper limb tension test.
Thank you, sir.
Sure.
Any other question? I think sir, no one have any question now.
Okay, I think आज बहुत ज़्यादा extra time नहीं लिया मैंने. I hope I tried to keep it within that time frame. I do understand that it's a very big topic. I tried to touch and cover all the outlines of this topic. And of course, there is a lot more to learn about this. There is a lot more to practice about these techniques. But if you even have any further queries, you can also send your queries to Shazia, and Shazia can just send me an email, and I'll be happy to answer you if you have any queries.
Thank you, sir. Thank you for this wonderful session and sparing your time for us. Thank you very much,
Sure.
sir.
Thank you,
sir.
Shazia. I think you have been great,
Thank you, sir.
and I think your students are great. And thank you for this chance to interact with them and sharing what I know. And सभी को हैप्पी जन्माष्टमी. मुझे पता है इस त्योहार का दिन है और सुबह सुबह सबको लेक्चर अटेंड करना पड़ गया. But I hope you all enjoy your day.
Thank you. Thank you, sir.
Thank you. Thank you very much.
Thank you,
Thank you,
sir.
sir. Thank you, sir.
Thank you. Thank you.